So it is an important topic, cancer, isn't it? It's the leading cause of total disease burden in the Australian context. We use about 19% of the total burden of disease in this country. The numbers are huge, 114,000 new cases in 2009 and rising rapidly. So by 2020, 150,000 approximately patients. The next bit's wrong. It's actually 1 in 2 men and 1 in 3 women. So 50% of all the men and 33% of all the women coming through your practices by the age of 85 will have had a cancer diagnosis. And that's excluding non-melanotic skin cancer. And there's this common prevailing myth that primary care doesn't see much cancer, but actually it's massive. It's only around about 1 new case of breast cancer per GP each year, but when you add the reality together that there are over 100 different cancers, the numbers kind of stack up. And I'll talk a little bit about survival a little bit later on, but there's also this increasing prevalence because we're now curing more people with cancer, that there are people coming through your practice all the time who maybe have some hidden problems that you're not, that are not really in front of you. So these are the top 5 cancers for incidence and mortality in Australia. So prostate, bowel, breast, melanoma and lung cancer are the top 5. But from a mortality perspective, lung cancer's our top cancer, bowel, prostate, breast and the lymphoid cancers have a high mortality, so they come up even though they're rarer cancers. Lung cancer's an interesting one really because there's a lot of new evidence coming through around improving outcomes in lung cancer, and I'll talk a little bit about that in a minute. So clearly it differs by males and females, so males have the higher burden of disease, and what we're seeing is that the incidence is rising but the mortality is falling. So lots of new things and good things are being done for cancer that we need to be aware of, because we know that within the general population there's a reasonable level of fear and concern, and so that leads to things like delays in presentation of symptoms to the GP, and all of those things can influence outcomes, and I'll talk a little bit about that as well. This is just looking at it by gender. So the incidence in males, that horrible spiky funny thing, is really all around prostate cancer, and I'm sure that's one of the dilemmas in your own practices. How much surveillance of prostate cancer do we need to do? And I'll talk a little bit about that in a moment. Cancer Services and Information at the Cancer Institute in New South Wales, and it's our pleasure to host this breakfast this morning on cancer control and the role of primary care. How many of you feel like you've got an active role now in cancer control? In any way? The odd hand? You're here because you're interested in cancer? Okay. So, I've got to just work out how to bring up my slides. So it is an important topic, cancer, isn't it? It's the leading cause of total disease burden in the Australian context. We use about 19% of the total burden of disease in this country. The numbers are huge, 114,000 new cases in 2009 and rising rapidly. So by 2020, 150,000 approximately patients. The next bit's wrong. It's actually 1 in 2 men and 1 in 3 women. So 50% of all the men and 33% of all the women coming through your practices by the age of 85 will have had a cancer diagnosis. And that's excluding non-melanotic skin cancer. And there's this common prevailing myth that primary care doesn't see much cancer, but actually it's massive. It's only around about 1 new case of breast cancer per GP each year, but when you add the reality together that there are over 100 different cancers, the numbers kind of stack up. And I'll talk a little bit about survival a little bit later on, but there's also this increasing prevalence because we're now curing more people with cancer, that there are people coming through your practice all the time who maybe have some hidden problems that you're not, that are not really in front of you. So these are the top 5 cancers for incidence and mortality in Australia. So prostate, bowel, breast, melanoma and lung cancer are the top 5. But from a mortality perspective, lung cancer's our top cancer. Bowel, prostate, breast and the lymphoid cancers have a high mortality, so they come up even though they're rarer cancers. Lung cancer's an interesting one really, because there's a lot of new evidence coming through around improving outcomes in lung cancer, and I'll talk a little bit about that in a minute. So clearly it differs by males and females, so males have the higher burden of disease, and what we're seeing is that the incidence is rising but the mortality is falling. So lots of new things and good things are being done for cancer that we need to be aware of, because we know that within the general population there's a reasonable level of fear and concern, and so that leads to things like delays in presentation of symptoms to the GP, and all of those things can influence outcomes, and I'll talk a little bit about that as well. This is just looking at it by gender. So the incidence in males, that horrible spiky funny thing, is really all around prostate cancer, and I'm sure that's one of the dilemmas in your own practices. How much surveillance of prostate cancer do we need to do? And I'll talk a little bit about that in a moment. But at the same time, is that a pointer? No. One of these is a pointer, that's a pointer. So one of the things is this is the incidence of prostate cancer, but actually the mortality from prostate cancer is reducing. So it's a disease where the harms and benefits of things like engaging in PSA screening need to be addressed. From females, the female perspective, obviously the big one is breast cancer, and again this is all around earlier diagnosis, but quite good reductions in mortality. So the critical factors in a cancer context that contribute to cancer survival are earlier diagnosis, better diagnosis and staging, and better treatments. So we're seeing from an earlier diagnosis perspective, overcoming community attitudes and fears around a cancer diagnosis are really important. If you're diagnosed with a stage 1 breast cancer, your 5-year survival is 95%. If you're diagnosed with a stage 4 breast cancer, it's more like about 27%, and you're living with the effects of advanced disease over a long period of time. And so the community message around early diagnosis in all cancers is really critical. There's also the prevailing myth, if you think about early diagnosis in a disease like lung cancer, that it's a cruel hoax to even begin to think about early diagnosis in lung cancer because you die anyway. But in fact, from our data, for those patients who are diagnosed with a resectable early lung cancer who go on to have a surgical intervention or a curative intervention, their 4-year survival is 70%. So in fact, it isn't a necessary thing that everybody will die of lung cancer. It's just that we need to change our attitudes and the ways in which we do that. How many of you are from New South Wales? So some of you have been watching the TV recently and seen the new Listen Out for Lung Cancer campaign. So that's the first campaign in Australia really to try and change community attitudes around earlier presentation with lung cancer as part of a major push that we're trying to undertake at the moment to reduce the kind of barriers to presenting with symptoms in lung cancer. And of course those patients are the complex ones in your practices because they're also the people who are presenting with chronic obstructive airways disease and other sort of impacts of smoking, and so that the symptom, the ability to really sort out the symptoms is more difficult. So it's really important with people with high risk factors for lung cancer that there's an engagement and a continuity of relationship with health professionals in a primary care setting, because sometimes it's a subtle change in their symptoms that is the indicator that they need to go on and have more investigations. And I'll talk a little bit more about that in a minute. So better diagnosis and staging really means that where patients have got complex pictures, we should be having referrals for particularly radiology tests in practices that see a lot of cancer, because there's quite a lot of evidence that the ability to detect cancer relates to being able to see enough of it. And there's also lots of now differences in the way in which cancers are treated depending on stage, and so diagnosis and staging is one of the critical interfaces between the primary and acute care setting. And from a treatment perspective, lots of multimodal treatments, so patient treatment is now much more complex. Most patients will receive more than one mode of treatment, and those treatments are now being delivered with higher precision. So the kinds of attitudes that some of your patients will have to saying, well, I don't really want my cancer treated because I'll get burns from the radiotherapy, or the chemotherapy is going to make me very sick. Those kinds of symptoms are also changing, so the symptom burden associated with treatment is reducing as treatments become more precise. But there's also part of the reality is that the interface between primary care and acute care from a cancer control perspective is not as good as it might be. So the acute sector, where I've come from, is very bad at communicating with the primary care sector. We have very poor points of interface between the two sectors, and those are some of the things that I think we'll see some rapid changes with. So just to start with, how many of you notice the cancer patients in your environments? How present is it? Is it something that's kind of high on the radar screen or low? High? What sorts of issues are coming through? What are the concerns you have in this space?
Probably, for myself, the greatest concern is the support for the carer, the family, in how to support the individual through the journey. The costs are phenomenal for, I live in Queensland, so for a lot of the costs, there's an awful lot of travel involved, accommodation away from home, and subsidies aren't even close to assisting.
Yep, so issues around support for families, out-of-pocket costs associated with travel. So you'll be pleased to know that there's a review of IPTAS at the moment, and we're trying to put some submissions in that really relate to, it's not just about the people, so that it is around very far away, but also the reality that sometimes people have got to travel even from communities where there are services because they need to go for specialist services. So quite a lot of issues around that. Other issues? That gets it, does it? She's well done, you've got it all. What sorts of roles do you see your practices playing at the moment in cancer? What's the predominant sort of thing? Diagnosis? Yep. So palliative, yep. So the follow-up or looking after patients after they've kind of come back. We talk a lot about the fact that the acute system has a capture, no release program, and you only actually see the patients when they need to come back for that. Is that the sort of feeling that they often disappear off your radar screen once we've captured them?
It depends, I think, on each individual practice. I tend to be a bit of a catcher myself, but not release easily. So it's sort of an overseeing of the whole journey to ensure that there's that consistent person in their life or support.
Yep. Yeah, so primary care has a potential role to play in care coordination across the journey, particularly for patients who have to move across a lot of settings. So one of the we have a primary care coordinator at the Cancer Institute. So at the moment it's Beverly Herbert over there, and Natalie is also there. So Natalie and Beverly are our two sort of primary care people. We've been around and visited every Medicare local across New South Wales over the last 12 months, even right out to the back of Burke. And one of the primary things that's coming out of there is the missed opportunity for the care coordination role of primary care, and the fact that, so we fund in New South Wales care coordinators. Most states fund care coordinators, but we funded them out of the acute sector, and what happens is they're coordinating the acute journey but with very little relationship with primary care. So one of the things we're trying to really foster, except WA, I think WA primary care has the coordinators over there have a much better interface. So this is a summary of the kind of the ways in which we need to be thinking about primary care from an acute primary care interface. This was adapted by John Emery. Do people know John? John's a professor of general practice in primary care, ex-Curtin University, in the process of transitioning to the University of Melbourne, who did a rapid review for us on the role of primary care in cancer. And what this is really saying is, if this is the patient journey from prevention through diagnosis, acute treatment, and sort of out the other end, that there are three really critical places or interfaces for primary care. The first is obviously the one around early detection and prevention, referral and diagnosis, and it is the one I think that's most advanced. But what GPs and primary care practitioners report is that there's not enough guidance for the specific diagnostic pathways that are required for cancer, and very poor sort of ability to communicate across this relationship. So everybody says, well, there's a Medicare item for multidisciplinary teams, and there's an ability to bring the GP into this. But our own experience is that that's a really difficult thing to do. We used to, when I was working at Peter Mac, in the breast unit, we had a full-time care coordinator who spent most of her time actually trying to set up those teleconferences and get the GP involved, because you can't, the time frames and the ways in which the practices work are different. So we need to really rethink how such billing items might be used more effectively, perhaps as a communication post the meeting of the team or pre, so that the communication is achieved in a different way but is still able to be resourced. The second interface is the interface at the point of treatment and into survivorship, and this is often actually seen as a transition, as in patients get put in here and that's the acute sector's job, and then they come out the other end and then suddenly there's a primary care job, and there's a recognition that this interface needs much more attention for the communication and the interaction between primary and acute care at the point when the patient is having treatment, because increasingly cancer treatment is actually delivered in the ambulatory environment. So the reality is that most of the patients are actually at home through most of their treatment journey, where there are opportunities for a much greater role for primary care, particularly for those patients who live some distance from their treatment facility. And then the third interface is really the ability for primary care to work more effectively at the transition for when patients actually might be entering palliative care. And I'll talk a little bit more about that in a minute. So if we try and work across that journey, obviously primary prevention is something that you guys, is one of the things that's the bread and butter of your practice, right? So the kinds of interrelationships between all of these. There's a lot of evidence, obviously, around tobacco as primary prevention for cancer, and I'm sure everyone's aware of that. There's now an increasing evidence for the role of diet and weight. So it's really the exercise to dietary ratio and cancer. Not just in the prevention of cancer though, but also in the prevention of recurrence. So in breast and bowel cancer, there's lots of evidence that after you've been treated for bowel cancer or breast cancer, maintaining a healthy weight and good exercise actually lowers your risk of recurrence into the future. Yet for women with breast cancer in particular, having been treated for breast cancer actually is a risk factor for weight gain. Most patients during their breast cancer treatment don't lose weight, they actually gain weight. And after the cancer journey, or the treatment journey, they still put on weight. So the sorts of messaging for people in survivorship really needs to begin to place some emphasis here. Similarly with alcohol, alcohol is a class 1 carcinogen. That's why we're having breakfast, not a reception at night. But it really is a powerful carcinogen. Lots of debate in the cancer literature about whether the recommendation should ban alcohol altogether or recommend against drinking alcohol altogether, given that the sorts of messages we're kind of seen as the bar humbug people of health messages. But in fact, in breast cancer, drinking more than 2 glasses of alcohol on a regular basis significantly increases your risk of breast cancer. So, sorry, have you got a dinner tonight? Yeah. Last night. Oh, too late. Sorry, too late. And clearly, sun exposure is another one that's big in your environments. So, healthy behaviours. This is New South Wales data, but it would be similar across the rest of the country. Only about less than 10% of people eat enough vegetables from a bowel cancer prevention perspective. People eat enough fruit, or 56% of people eat enough fruit, so we're doing better there. Only half of us get enough exercise. How many people went to the gym before breakfast this morning? Good girl. We've got a healthy person in here. And only about 43% of Australians have a healthy weight. And in fact, I was looking at something, watching something the other day about this from John Funder, where actually this is getting worse, not better. And we're now officially more obese than the United States. Or a greater proportion of us are overweight. They have a higher proportion of the people at the extreme obese end, but Australia's a real problem. And the other emerging piece about this is that what mothers do in the year before their baby is born in terms of weight may have an impact on the weight of their child, and those kinds of things all through life are impacting on our risk of cancer and other chronic diseases. This is the smoking data. You can look while you're eating. So we've gone from 97 having a 24% smoking rate in New South Wales to about 14.7% now. So it's getting better, but the rate of lung cancer is obviously still rising because of the 20-year lag. There's a whole lot of new kinds of campaigns, but you'll see that this is when health warnings went in on packaging. So it does have an impact. And this is point of sale banning that went on in New South Wales, so there's a drop since then. And now, of course, we'll see the impact of plain paper packaging or plain packaging. We've already seen massive increases from the plain packaging work on calls to the quit line. And so lots of excellent activity in an Australian perspective. This is just really looking at the proportion of cancer deaths from lifestyle risk factors. So all the things we've talked about really are quite minor players in terms of tobacco. So the proportion of cancer deaths from tobacco is 39%. So we're not just talking lung cancer, we're talking bladder cancer, head and neck cancer, a whole range of cancers impacted by tobacco. So some of you will see new campaigns coming out there around shared quitting, trying to create quitting behaviours in a family context. So I'll give up chocolate if you give up your cigarettes kind of relationship. I'm not sure that you will relapse. Yep. Yeah.
How do they actually draw that out with those percentages?
So these are all done on complex risk modelling at population-based level, so health surveying of very large groups of patients and then, or of people, and then looking at all the things they've done over their life and attributing risk to all these. So they're largely theoretical or modelled outcomes. It's not precise, and each of these will have an overlap. So if you drink alcohol and you smoke, your risk of head and neck cancer rapidly increases because there's a synergistic relationship between those two factors. Yep. This is the data on young people and sun. We're becoming increasingly concerned that these messages are not getting through. So we've still got 78% of girls and 72% of boys who get sunburnt at least once every summer, which and the sun burning in young people in particular, and the risk of melanoma is very high. Some of you will have seen campaigns like the Les Bonny campaign on the TV, and that's all related to trying to show the relationship between sunburn and cancer. The newer campaigns internationally are actually showing the relationship between sunburn and ageing, and you can get fantastic computer modelled things around the relationship between sun and your skin age, and also between smoking and your skin age. And we think that that might have a more powerful effect on teenagers if they think they're not going to look good, as opposed to the fact that they might get melanoma. So what are the sorts of cancer prevention and screening activities that you currently run in your practices? I'm going to really interrupt your eating now, aren't I? So, yes, so you're doing fecal occult blood testing. I'll talk a little bit about that in a minute. What else? Sorry? Pap smears. So how many of you as practice nurses are performing pap smears in your practices? Okay, so only a few. Yep. Skin checks. Vaccination for Hep B. Good. PSA testing. Yeah, you want to talk about that? The GPs tell me that that's actually the biggest dilemma in their practice, and I'll talk. So these are the kind of 5 things that largely get screened for at the moment. So breast and cervical, clearly there's national programs around breast and cervical cancer screening. Participation rates are incredibly varied and always too low. So around only around 50% on average of the adult population are participating in breast and cervical screening, as in the female population. Breast cancer screening, are you getting many queries about the controversies of harms versus benefits in your practices? Are patients raising these? So there's a lot of academic literature around the potential harms of breast cancer screening, mammographic screening. These relate to that the harms versus benefits data is actually quite old, as in taken from Impact a long time ago. But it's really based around the idea that some breast cancers will not progress in that patient's lifetime. So the older you are, there's likely to be more potential harm, because the patient would die of something else before the breast cancer actually was a cause of their death, which is one of the reasons why the screening program covers a target age group where the benefits are likely to be bigger. The other harms really, though, are associated with the invasiveness of treatment. But there's no data on that can be used from a breast cancer biopsy to decide that would be an indolent tumour or not. And so until we've got much better ability to look at a particular section of it or biopsy of a breast cancer and actually say this is not biologically an active cancer, there still will be benefits to breast cancer screening. There's also an awful lot of work going on around trying to improve mammographic screening. So there's now some emerging evidence that 4D versus 3D screening allows you to identify more cancers but actually rule out some of the lumps as not being cancer. And so I think the emphasis is really on improving outcomes. The other thing the mammographic screening program of course does is raise community awareness, and that has had a major contribution to improved outcomes from breast cancer. Cervical screenings, the poor participation rates in the cervical screening program are also of course problematic in the context of HPV vaccination, in that the women of the future will think that they have been vaccinated and so they don't need to participate in cervical screening. And so lots of issues in here about what we do, but we have some of the poorest cervical cancer outcomes in the world in our Indigenous population. So for those of you who work with Indigenous populations, cervical cancer should sort of kind of be one of the number one things on the list for trying to look at programs to improve participation rates amongst our Aboriginal Australians. Bowel cancer, we have the second highest incidence of bowel cancer in the world, second only to my compatriots from New Zealand and Natalie's as well, and Beverly, we're all Kiwis. So we have, yes, the highest rates in the world, but we've got a national screening program that is confusing in the extreme. Why is it confusing? Why is the national bowel cancer screening program confusing? Yeah, so recommended best practice is a 2-year screen and our national program is 5 years. Why else is it confusing?
Sometimes it's free, sometimes it's not free.
Yeah, sometimes it's free, sometimes you get a kit in the mail, other times you're in a Rotary program or a Bowel Cancer Foundation program. So there's multiple players, there's multiple types of kits, the messages are confusing. So there's a lot of action at the moment trying to convince the federal government that they just need to move to a national program that meets national guidelines and stops the confusion. We've got also low participation rates in bowel cancer screening. Why might that be? Why do you think our participation rates are low? Any of you as old as me and have got your first kit or your second kit? What did you reckon?
Yeah, around that. I don't use my kit because I've got a family history of bowel cancer, so I get screened in a different way.
Yeah, so some for some of us it's because we've got family histories of bowel cancer and we're screened.
People just think it's messy and embarrassing.
Yeah, so they think it's messy and embarrassing. The laboratories tell us that patients actually sometimes bring in having taken the whole stool out of the toilet and put it in a jar and brought it in, so the laboratories get very confused. The kit is really difficult to understand. Janet MacDonald, who is the wife of the ex-head of the Australian Broadcasting Corporation, used to sit on the board of Cancer Australia, and one day arrived in and she said, "What's this?" And she's a very intelligent, very bright woman, and she'd just got her kit and she couldn't understand what to do with it. So God help you if you don't have high levels of health literacy, your first language isn't English, about what you actually do with the kit when it comes in the mail. So there's a lot of work to be done about how we actually promote bowel cancer screening in a way that demystifies this. But we also need to find better ways of doing it. So one of the things that's happening at the moment is the Commonwealth, the CSIRO organisation is trying to develop a blood test for bowel cancer screening that they have actually now got in clinical trials, and will mean not only can you detect bowel cancer from a blood test, but you will also be able to detect whether or not something needs to be done about it. So that'll be very interesting. Lung cancer screening. What do we know about lung cancer screening? Sorry? There isn't any? Okay, so this is one of the ones that's quite interesting. There's now some big studies out of the United States and some more emerging from Europe that shows in high-risk individuals, that is people with a 30-pack year smoking history or currency, actually do benefit from low-dose CT scanning. And to the tune of a 20% reduction in mortality in this population. So you'll start to see some experimenting and pilots of low-dose CT in high-risk individuals in Australia. How many of you are from Brisbane? Anyone from Brisbane? Okay, so Kwong Fong is doing some of this work in Brisbane. He's a respiratory physician, and you will start to see it. It's being discussed by the Commonwealth Government at the moment around this. So one of the things that will be really confusing for primary care is who is it that we need to screen, and it'll start to sort of popple up like this without kind of any guidelines. So we're trying to do some work in this space to be able to do some information. The first thing is actually, what systems have you got in place in primary care to recognise who might fall into a high-risk individual category. So we'll be doing some work in that space. And obviously skin cancer screening is quite tricky, but knowing something about patient skin exposure is important. So I think I've talked about, probably the one I haven't talked about is the surrogate PSA screening. So we don't have a national screening program, and PSA is an incredibly imprecise test. And if you think overdiagnosis in breast cancer is an issue, overdiagnosis in prostate cancer is an even bigger issue. And there's real problems with the way in which men are given information. So they're encouraged to go and have a PSA test, but there's very little guidance on what to do if there is a positive test. And then there's very little guidance around the extent of treatment if you do need to have it. So there are some individuals like Bruce Armstrong, who's an epidemiologist in New South Wales, who argues that we should actually be creating a national register of PSA screening so that at least we can have a bit of an overview on what to do with it. The GPs say that they're seen as bad GPs if they say no to a patient who comes in seeking a PSA screen, and so there's no magical answer other than the production of much better information for patients to be able to make some sort of informed decision about the consequences of having a test and what happens. There's also the other piece that's very confusing in the response to PSA screening is if you do have a positive screen and you are diagnosed with a prostate cancer, there is a lot of controversy at the treatment end. So surgery and radiotherapy for early prostate cancer have equivalent survival outcomes, but very different side effect profiles, and mostly patients are referred to a urologist. And if they want to seek a second opinion, that urologist frequently refers them to another urologist, whereas in fact the second opinion for a person with an early prostate cancer is actually a radiotherapy opinion. And so these patients really need to be treated and seen within multidisciplinary teams that bring together a range of specialists because it's very complex. So what do you think can be done at a practice level to improve screening practices? Has there been any impact of the changes in Medicare rebating for nurses doing cervical screen? Has it driven it out?
Basically, I have 70 practices in my area, and there would probably be 2 practices that still actually encourage their nurses to screen and cover that by the payment rather than the item number.
Okay, yeah, so that was our concern, was that it was driving it down, whereas the practice nurse is the ideal person to be really taking up the cervical screening mantra. So it'll be, make sure you kind of get that information going up and out of practices, because I don't think there's much awareness about what So because it changed from being a payment to a practice incentive, kind of an overall thing, isn't it? So the practices that are committed to the role of nurses have a different attitude to some of that than the ones that are not, right? What other things are happening from a screening perspective? So do any of your GPs do things like have all the reminders turned on in the medical director? So the Victorians have done some work on adding bowel cancer into the screening reminders. So there's some work that can be done on the software programs to actually bring breast, bowel and cervical screening into the reminder systems in the electronic systems. So we're just helping to develop some tools to be able to do that across the system. So automated reminders are actually really important. So there is evidence that patients who attend practices that have reminder systems in place actually have higher screening rates than those that don't. So it is an important activity. The other thing about reminders is actually a GP recommendation. So there's been some work in New South Wales on letters associated with the cervical screening program, and that in addition to the kind of letter that comes from the registry, an actual tailored approach from the GP does make a difference to take up. There's also some thoughts around the need to develop tailored screening plans as part of the care planning for patients who are in the practice, and that those kinds of things can make a difference, and the identification of high-risk individuals. And I think that what for you is this in the same way as it is for every part of healthcare, this kind of a one-size-fits-all approach to practice doesn't work anymore, and that we need to be able to really tailor our approaches to practice based on the risk profiles of patients. And so I think that there's a lot of work that we need to do around helping practices to identify the system or the profiles that might need to be the profiles of target. So from a diagnostic and referral process, so obviously one of the critical issues is knowing what symptoms are important and when something needs to be done about them. But then knowing where to refer is also really important. In New South Wales, what the Institute has done is developed an online referral website called Can Refer. What it does is it lets you sort by cancer. It defaults to searching by multidisciplinary team and also by postcode or how far the patient might like to travel. And within 26 seconds, you can identify the contact details for a multidisciplinary team relevant to that cancer for referral. It contains all of the information about the names of the doctors, what their room numbers are, and what the patient needs to do if they're going there, what the parking's like, whether they need coins or a credit card, all of that kind of information. We're trying to promote this platform to other jurisdictions. It's freely available for them to populate. Lots of jurisdictions did referral directories as part of the Cancer Australia CanNet program, so some of the information exists in different ways. But this really is beginning to make a difference in really the ability of primary care to identify quickly the best places for their patients to be referred to, rather than relying on who you went to med school with or other kinds of traditional referral pathways. It also it works. The patient might be wanting to go somewhere so they can stay with their daughter, and you can put the daughter's postcode in and be able to do that. Over time, what we'll be able to do is fill this up also with more information about referral pathways and GP guides, so that those things can be more tailored. And there'll be information on the booth, right, about Can Refer, so the guys have got that. So the other sorts of things that are happening in this space are diagnostic and referral tools. So some of you might be familiar with the Cancer Australia lung cancer tool, which is around symptoms and diagnostic pathways and referral, which was released late last year. In Victoria, there are other patient management frameworks. Are any of the Victorians familiar with those? They're on the Health Department website, and they're quite useful in identifying up front the primary care. These frameworks have been taken up by COAG, and they're currently at the Commonwealth Heads of Government Committee. There's a cancer expert reference group that comes out of the national program, and these patient management frameworks are now being adapted to be national frameworks, so that some work happening at the Cancer Council of Victoria on behalf of the Victorian Government to do that. We've talked a little bit about care coordinators already, but knowing who the cancer care coordinators are in your state, most states have them now. In Victoria, they're only in the regional integrated cancer services. In WA, there's a state-based approach to care coordination, and in New South Wales, it's hit and miss, depending on whether you got money when the Institute rolled it out, but we're just trying to look at that. The other major piece of work that's beginning to pop up is rapid access clinics. So the idea would be that rather than the GP having to be communicating with a consultant and having sent them off for a chest x-ray and then off for a CT scan, and then do they need to have a PET scan and all of those things, that actually that's a one-stop referral into a rapid access clinic so that everything can happen in a much more timely way. In breast cancer, that's happened quite effectively. Most of the patients that you would see with breast cancer would get into the system quite quickly. Is that fair? Particularly, I guess, if they live in a metro area. Rural might be more difficult. We had a national workshop on lung cancer on Wednesday, and everybody said, so what's the gold standard for referral pathways? And everybody talks about breast cancer, and then they say, well, that can't be done for lung cancer because of this, this, this and this, and they started to set a standard that says from suspicion to diagnosis in a month. And everybody said, why, if you can do it in a week for breast cancer, can you not do it in a week for lung cancer, when in fact it's a more rapidly progressive, time-critical cancer than breast cancer anyway. And so I think there'll be lots of work coming out in the space. I'm going to Denmark tonight. They've developed a whole-of-system rapid access approach for cancer diagnosis, and we're going to go and have a look and see what they're doing. Because if it can be done in some jurisdictions, it can be done in others. And it's really interesting the extent to which clinicians don't see this as a system issue. They see it as a people piling up outside their door issue, and that all I've got to do is have more of me or work harder, as opposed to... So we asked the question on Wednesday, so how many people do you diagnose with lung cancer, as an example, in your facility every week? And the answer was 4. So why don't you have 2 CT slots, PET CT slots on a Tuesday and 2 on a Thursday, ready for those patients to slot into? It's like, it's not rocket science, is it? And yet that's not how people are thinking. The new patient arriving is a surprise, and then we have to start getting the system to set up around that patient instead of actually setting up the system and slotting the patients in. Whoops. Go back. So care coordination, I think, is a big issue, and I do really believe that one of the things that we'll see starting to happen is much more formalisation of the care coordination role of the primary care setting, because patients are increasingly treated across facilities. They're all, as I said, ambulatory, and we need to really understand how to do that. During treatment, in the capture no release world, you don't see the patients, and it's our view that you need to be able to see the patients and at least understand what's happening for them. We've done some work previously. Michael Jefford, who's a medical oncologist that I worked with, just did a simple thing for patients having chemotherapy. We trialled faxing a sheet to the GP about what the patient was having and what were the side effects and what would you need to do about them. And just that simple intervention increased GP confidence and their willingness to see the patients during treatment. some of the formalised ways that kind of information is available is through EviQ, which is the Cancer Institute's Cancer Treatments online website. 27,000 users on that system. You can register for the system, you can go to the booth and have a look at it. But this is a web-based information repository that's now in the process of becoming a national collaboration. So the usage in many of the states is as high as in New South Wales, so even though it's been a New South Wales development, it is used across the country. And now we have a primary healthcare section that Natalie has led the development of, which actually tailors some of the information that's in the system for specifically for a primary care audience. There's lots of nursing procedure information, so the sorts of management of side effects and other things are in there. There's also information for patients. So if you've got a patient who's about to have a particular treatment protocol, you can go into the system and actually get that information and be quite proactive about that. The system, as I said, it's web-based information, it's evidence-based, it's free, it's peer-reviewed and maintained, so each of the sections of protocols, so for example, medical oncology has a reference committee made up of clinicians from across the country who work with the EviQ team to review the material, and it's very applicable to the Australian environment. So it's a really useful resource and one that I would encourage you to have a look at. So survivorship, just getting towards the end of this. So more than 60% of people overall survive cancer now. It's as high as 95% in some cancers that are diagnosed. And the reality is that the acute sector, follow-up in the acute sector long term is both undesirable and unsustainable. We have medical oncology practices in this country who don't see new patients because their books are full. It's like, how insane is that? Because what they're doing is seeing follow-up patients for years and years and years. It's insanity. And there's no evidence that active surveillance in a specialist follow-up actually improves outcomes. It doesn't detect cancers or second cancers or recurrences earlier, and even if they are detected, it doesn't improve survival. So we're doing something that is, we've got a follow-up model of care that actually doesn't make any sense at all and keeps the patient caught into this annual or 6-monthly cycle of anxiety. They might drive. When we were in Burke, we heard the story about the bus that takes the Aboriginal patients to Dubbo for their follow-up appointments and back again. That's a 9-hour round trip, for a 7-minute encounter that you probably wait another hour for that doesn't do you any good. So these models are insane, and there are significant bottlenecks occurring for timely access to appropriate treatment. The doctors say, the specialists say, but it's nice to see some patients who are actually doing well. I say have an annual party and bring them all in and say hello to them. Don't fill up the clinics with them. So there's lots of emerging exciting things for survivorship follow-up. So it's about, and now at the moment there are over 700,000 Australians alive within 23 years of a cancer diagnosis, and that's just going up daily. It's predicted to be 1 in 13 of your patients by 2020. 1 in 13 of the general population will be a survivor of cancer. And so there's, in the acute sector, lots of new examples about nurse-led follow-up models. At Peter Mac, patients with early prostate cancer who are on some of the sort of limited surveillance models are getting a nurse-led telephone follow-up model, so the patients are not even having to come to the clinic anymore. Primary care follow-up of lower risk patients is starting to increase, so John Emery's doing some work on follow-up in prostate cancer. Michael Jefford is leading a study at the moment on primary care follow-up in bowel cancer, and some of it is around this whole notion of risk stratification that's in here. Who has very low risk of either recurrence or long-term side effects or acute side effects, who has moderate risk and who might be higher risk. And so moderate risk patients with specific needs for links back to their system fit really well with shared care models. And often the mediator of that is the cancer care coordinator in the acute system out through to the practice, potentially to a practice nurse, I would think would be quite a nice model. And so starting to see some research coming out of this. And then there are people, I'm assuming somebody who's a professor of oncology in Queensland, who's managed to join up 750,000 kilometres of far north Queensland into one oncology practice, predominantly run through telehealth, where the patients no longer travel, they don't travel for their first appointment. He sees them as their first appointment on a telehealth consultation at the GP, in the GP practice, and then their first follow-up after treatment is also by telehealth, and then sometimes it's just telehealth with the patient as they get lower and lower needs. So the amount of savings in the system from doing that, let alone the benefits to the patient, are incredible. But there are obviously lots of barriers. Some of the barriers are attitudinal, in the sense that we hear from some of the GPs that they have concerns about seeing the patients because they don't have the skill set. So how do we address those barriers? But the biggest barriers are probably attitudes in the acute sector that says that primary care doesn't have the skills to manage the patients, and more importantly, how those attitudes transmit to the patients who actually have been through something pretty scary and then attach their trust and faith back in the acute system and don't want to be returned. There's a great paper that's been published recently called Not What I Want But Probably What I Need, which is about patient attitudes to being returned to primary care. And we've got to do lots more to actually build the systems that actually mean that the patient doesn't feel like they're being abandoned by the treatment team in being returned to primary care, but actually managed together in those kinds of approaches. So we're bang on 8 o'clock, so I won't hold you up, but just in terms of palliative care, this is obviously a long-standing role for primary care, and I wouldn't want to teach you to suck eggs in it, but I think there are some emerging challenges with some of the new ways in which primary care is being delivered in group practices, and perhaps not the same continuity that used to exist in family medicine. But people who are receiving palliative care need continuity, they need after-hours support, and they often need home visits. And these things are becoming much more difficult to deliver in current practice models. And one would think that there's a kind of a nursing potential role in here if we can get the funding models right for some of that in association with palliative care services. But the problem is that what this is doing is leading to more deaths in hospital. Cancer in New South Wales is second only to coronary artery disease in ED presentations in the last year of life. And it's potentially avoidable and not that fantastic for the patients. So, in conclusion, I think there is a critical role for us to think about how we expand the role of primary care, and indeed the role of practice nurses in all aspects of cancer control. There's lots of emerging evidence internationally that this can improve the journey for the patients and their experience, that it can reduce healthcare costs, and it can actually give better access through the reduction of bottlenecks. But that we've got to start looking at the investment and the initiatives and the development of models of care. So, any final bits of questions or discussion that anybody, things I haven't covered that anybody wants to raise? The other thing I didn't mention is there's an online, a website called cancerlearning.gov.au, if people come across Cancer Learning, which has got a lot of teaching resources, and in particular within that there's a section called EdCan, which was the Australian National Cancer Nursing Education Project that Patsy Apes and I led a few years ago. And there's lots of really good materials in there if you're wanting to do professional development in cancer that are readily accessible and in a language that makes it easy to learn. I think lots of case-based learning. Yep.
Do you have any...
Just yell at me and I'll repeat it if you like.
Do you have any recommendations about funding models for involving primary care more in this treatment and screening?
So that
you yourself or the Cancer Institute have any input into changing the funding models?
what we've been trying to do is actually invest in pilot projects to develop the models and then be able to try and work with practices to establish those within the existing funding models. Part of the problem is that there's often a funding stream if you can actually set things up to access it. The multidisciplinary care one is the one that I think is the biggest issue, and we've been having some conversations about how we might influence the federal government about rethinking the way that, because the way it's described at the moment is you have to have, I think it's 4 disciplines actually in the same room in order to, even if it was by telephone, in order to access it, versus actually doing it as a non-simultaneous consultation. So it definitely needs some work. Yep. Was there some questions? Don't want to make you late for your session. All right, well, thank you very much, but please follow up with Beverly and Natalie on the stand if there's anything we can ever do to help. Let us know. Thanks.